This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the journal Medicine, published in 2026, titled Development and Validation of a Prediction Model for Postoperative Cerebral Edema Progression in Emergency Traumatic Brain Injury Patients.
This is a topic that hits home for anyone who spends time in the neuro-ICU. We take these patients to the OR for life-saving measures, decompressive craniectomies or hematoma evacuations, and we think we've turned a corner. But as this paper points out, the surgery itself can act as a secondary insult.
Exactly. The authors, Zhang and colleagues from Qingtai People's Hospital, highlight that while we're relieving herniation, the perioperative period can actually induce or exacerbate cerebral edema. The real challenge they address is that by the time we see obvious clinical deterioration or radiological shifts on a follow-up CT, that therapeutic window for intervention might have already closed.
Right. We've all seen it. The patient who looks stable on the immediate post-op scan but then blows their ICPs 48 hours later. This study attempted to quantify that risk early on. Ilara, walk us through the study design.
It was a single-center, retrospective observational cohort study. They looked at 201 TBI patients admitted through the emergency department who underwent craniotomy between 2023 and 2024. They used a time-split method to divide the patients. 70% were in the model development cohort, and the remaining 30% were for internal validation.
And how did they define the groups?
They categorized patients into a cerebral edema progression group, which was 63 patients, and a non-progression group of 138 patients, based on imaging and clinical criteria within the first 72 hours postoperatively.
That's a significant percentage. Nearly a third of the patients progressed. To build the model, they looked at demographic, imaging, and laboratory indicators. What were the heavy hitters that actually made it into the final multivariate logistic regression?
They identified 7 independent predictors. Some are what you'd expect, but the specific odds ratios are quite telling. First, increased age. The adjusted odds ratio was 1.02 per year. Then, lower admission Glasgow Coma Scale scores, with an AOR of 0.86 per point.
So, for every point the GCS drops on admission, the risk of postoperative edema progression increases significantly. That's a vital reminder that the initial injury severity sets the stage for the secondary edema, regardless of how well the surgery goes.
Precisely. Then they looked at the imaging. A larger volume of cerebral contusion or hematoma had an AOR of 1.06 per 10 millimeters, and a greater midline shift had an AOR of 1.12 per millimeter.
The midline shift metric is interesting because it's such a simple measurement, but an AOR of 1.12 per millimeter means even a few extra millimeters of shift dramatically changes the risk profile. But they also included postoperative physiological data, right?
Yes, and this is where it gets very practical for the residents listening. The model includes the maximum intracranial pressure within the first 24 hours post-op, with an AOR of 1.11 per millimeter of mercury. They also found 2 critical laboratory markers: lower serum sodium levels within that first 24-hour window, AOR of 0.91 per millimole per liter, and elevated C-reactive protein, with an AOR of 0.03 per 10 milligrams per liter.
Let's pause on that sodium and CRP for a second. In the neurosurgical context, we're often chasing sodium to keep it on the higher side of normal to manage ICP. This paper really reinforces that lower sodium in those first 24 hours is a strong predictor of worsening edema, and the CRP confirms that systemic inflammatory response we often talk about in TBI.
It really rounds out the model, combining the mechanical injury like midline shift with the metabolic and inflammatory state of the patient. When they put all 7 of these factors together, the performance was actually quite impressive. In the development cohort, the area under the curve, or AUC, was 0.901.
0.901 is excellent for a clinical prediction model. How did it hold up in the validation cohort? Often these models look great on the training data but fall apart when applied to a new set of patients.
It stayed very stable. The AUC in the internal validation cohort was 0.875. They also used the Hosmer-Lemeshow test and calibration plots, which showed that the model's predicted risks matched the actual observed outcomes very closely. They even did a decision curve analysis to prove its clinical utility.
This is what I want our residents to focus on. We aren't just looking at a CT scan in a vacuum. We're looking at an 18-year-old versus a 70-year-old, the admission GCS, how much shift was there originally, and then, crucially, what happened in the ICU in those first 24 hours. If you have a patient with a high CRP, a sodium of 134, and an ICP that's hitting 18 or 19, even if the post-op CT looks okay, this model tells us that patient is at high risk for progression.
And that's the early warning the authors are talking about. If we can identify these high-risk patients before they clinically deteriorate, we can initiate targeted intensive therapies. The paper mentions things like optimized sedation, precise hyperosmolar therapy, or even prophylactic hypothermia.
It moves us away from reactive neurosurgery toward proactive management. Instead of waiting for the pupil to blow or the ICP to stay at 25, we're looking at the probability of edema progression. Ilara, were there any specific mentions of the stability of the model across different groups?
Yes, they conducted a subgroup analysis which verified the model's stability, suggesting it can accurately and stably predict risk across the emergency TBI patients they studied.
It's worth noting for our audience that while this is a single-center study, the fact that they used consecutive enrollment and a time-split validation method adds a lot of rigor to the findings.
Definitely. It's also one of the first models I've seen that really integrates that early postoperative ICP data and laboratory markers like CRP into a single cohesive tool.
For the practicing surgeons listening, how would you summarize the takeaway?
I'd say the takeaway is to look beyond the immediate success of the hematoma evacuation. We need to be vigilant about the 7 predictors: age, admission GCS, contusion volume, midline shift, max 24-hour ICP, serum sodium, and CRP. If those numbers are trending in the wrong direction, that patient needs a much higher level of surveillance.
Agreed. It's about individualized management. This model provides an objective decision support tool that we can use early in the postoperative period to justify more aggressive ICU interventions for those who need the most.
It's a great example of how we can use retrospective data to build something that has real perspective value in the trauma bay and the ICU.
Well, that's all the time we have for today. An excellent paper that I think will spark a lot of discussion during morning rounds.
Thank you for joining us on the Neurosurgery Hub podcast. We'll see you next time.
Stay sharp.